Dr. Arman Eshaghi is a National Institute for Health and Care Research Principal Research Fellow at University College London. Dr. Eshaghi, your work is at the very exciting intersection of neurology and artificial intelligence. For our audience, could you demystify this a little bit? How are you using AI, machine learning, to look at an MRI scan and see things that go beyond what the human eye can detect?
So first of all, thanks very much, John, for the invitation. It's always a pleasure listening to your podcast, and I'm very excited to be here today. AI as a term, also for patients, has been very generic and refers to lots of different ways and tools we use in processing brain and spinal cord scans. But what is probably most used both in the literature and what some patients, not all of them, some patients in some hospitals may see is the kind of AI that looks at mostly the brain images and processes those images for both disease activity, that is the white plaques, white matter, what we call hyperintensities or sometimes lesions, and also brain shrinkage. These are the two areas. And one of which is very difficult to quantify, that you can probably do only with AI, is the brain shrinkage over time. It's difficult with the naked eye, even by, for example, a neuroradiologist, to be able to detect that. So specifically, if I want to summarize, I would say detecting changes over time in a way that is more efficient than, for example, as an assistant to a doctor, and also to be able to quantify brain shrinkage in the hospital for patients.
A key promise of AI is the ability to predict. People living with MS live with uncertainty, and their quality of life would be fundamentally changed if they knew what the future might hold for them in terms of their disease course. Based on your modeling, how close are we to using a patient's initial MRI scan and clinical data to accurately predict their long-term disability risk, and more importantly, to select the optimal personalized treatment for that patient?
We have, over the past 10 years, we've made tremendous progress. We are now able, in a research setting, so I think it's very important for the public and for the people with MS and also the doctors to understand there is a difference between research and clinical care. So in the research setting, we've done a lot. So in various registries in the United States, outside of the United States, with different data sets, we've done a lot. So we are able to, with moderate and modest accuracy, we are able to tell in research settings, for example, how likely one person might be to become wheelchair bound within a certain number of years. In practice, however, we haven't really translated any of those to a practical tool for patients. So the short answer is, unfortunately, there's nothing as I speak in practice that can be useful, and there are lots of reasons for it, which we can discuss. But there's a lot of promise. We need a lot of more work. And as I said, I use the term modest. Even in a research setting, we can predict and have accuracy that is very modest, which may not be useful if we were to translate that right now for patients.
You mentioned brain shrinkage, brain atrophy earlier. You've published extensively on that. For a long time, this was seen as a diffuse late-stage event. How have advanced imaging and computational tools changed our view of atrophy?
So new brain is a very complex tissue, and the brain shrinkage happens in everyone. So if you're in your 30s, your 40s, you're losing your brain. So it's very sad, but that happens for everyone.
Right.
But what happens in MS, that happens much faster. But what is also interesting is that different parts of the brain, and depending how you calculate that, we can have more than 100 areas in the brain, they shrink at different pace. So what becomes interesting is that with the technologies we have with AI, we are able to quantify those, and we were not able to do that. So you're able, for example, to look at specific areas that might be better related to how you walk, or areas that might be better related to cognitive functioning, for example, memorizing events and so on and so forth. So this is where AI has helped a lot, again, in a research setting.
Do you see being able to use that information as a primary endpoint in a clinical trial one day?
So I think that's a very good question. So we are using that as a secondary endpoint as we speak. So and a primary endpoint in phase 2 trials. I think the question would be, as a primary endpoint in phase 3 trials, is a personal opinion. I don't think that, because it's very difficult to convince a regulator that actually corresponds with patient benefits, because how patients feel about themselves, about how well they are, doesn't necessarily correspond with how the brain is changing.
Right.
So the regulators, for really good reasons, they don't believe us, anyone else, if we were using that as a primary endpoint. Having said that, we have also seen recent, for example, BTK inhibitors, the recent classes of disease, that they actually don't have that much effect on brain shrinkage.
Right.
However, they help patients, for example, by delaying disability. So both my personal opinion and also the scientific evidence goes against, at this point in time, using brain shrinkage as the primary endpoint.
Looking ahead, what do you see as the ultimate vision for computational neurology in MS? Is it the creation of a digital twin for every patient, a virtual model of their brain and disease, where you could simulate the effect of different therapies before even prescribing them? What's a big goal that drives your work?
The big goal that drives my work is for patients to get access to their own data, to be empowered enough to be able to use their own data. So we do have this issue that there is less access to doctors, to specialists, and we discuss a lot about MRI. We are now able to, for example, look at the conversations patients are having, with their doctors. A lot of those conversations are not translated into, for example, predictions for future. So we can go above and beyond MRI in computational neurology, and that's exactly what we're doing. Includes, coming up with the disability measures that are hopefully better than what we call EDSS, which some patients may know about. It doesn't really capture disability in MS. That's one area that I'm very hopeful we one day might be able to use AI, not really solve MS all at once, but to have a better measure of well-being. That's the area I see can happen in the future. The other area I would say, so as you mentioned, for example, can I predict what I would look like if I were to receive treatment A versus treatment B? Yes, I think that is possible. But what is important is we've done a lot of AI and MRI. We really need to bring other aspects to the equation before being able to answer these sorts of questions. That includes socioethnic status, that includes comorbidities, that includes age. We've been excluding lots of patients, more than 55, 60 years of age for decades, so that's a big problem we have. We're now trying to correct the record, we're trying to be inclusive. So these sorts of problems that I think, there are low-hanging fruits that AI can bring to the predictive models and help patients. So I think, the next 3 to 5 years we'll see more in this area.
Well, Dr. Eshaghi, one of the things I really enjoy about talking with you is you give us a glimpse at what will be possible, a little glimpse into what future treatment might be, what future MS care is going to look like, and how that is going to improve quality of life for everyone living with MS. Thank you for the work that you do. Thanks for spending a few minutes talking with me today.
It was a pleasure. Thanks very much for having me.
This conversation was made possible through a generous grant from Sanofi.